Can value-based care models save primary care practices? Find out on today's Medical Economics Pulse.
Cataclysmic event as far as fee-for-service goes, with hundreds of billions of dollars of bailouts required to compensate hospitals and others for lost revenue from people not walking in the door for fee-for-service. Value-based care is fine, right? Like it hasn't needed a bailout, right? Like the models are actually, and we wrote about this, the ACO models are pretty robust.
Primary care is in the midst of a crisis. Many practices face the threat of closure as they deal with the fallout from the COVID-19 pandemic. So what can physicians do to save their practices and treat their patients effectively? Our guest today is Dr. Farzad Mostashari, the CEO of Aledade. His answer is physicians should embrace risk, and by that he means value-based care. He contends that the fee-for-service system has exacerbated these financial struggles, and that the way forward is to accelerate the evolution of how physicians are paid for providing care. In a wide-ranging conversation, we discuss value-based care, telehealth, and what the ideal primary care practice of the future should look like. Dr. Farzad Mostashari, thanks very much for joining us today.
Thanks for having me.
So the big question is, what is the state of primary care right now? What are they going through, and how do we fix primary care so that they can succeed in the future given the challenges?
Yeah, primary care has never been more needed. We have obviously a lot of need for primary care on the front lines of COVID. Primary care, we all hear about hospital workers who are at risk of COVID, but those patients who end up in the hospital first went to their primary care practices. And those primary care docs, unlike you and me, who get to stay home and socially distance ourselves, those primary care practices are exposed to every patient who walks in the door. They care for them. They close the door in a room with them, and oftentimes with inadequate personal protective equipment because the supply chain for those small practices is broken. They could not order masks. So those primary care, I think they're primary care heroes, have been caring for patients and also helping patients stay home and healthy, giving them the message of don't come in if you don't need to. But that means under their current business model of primary care, which is different from their heart or their caring model or what they really are out there to do, but their business model means they go broke because the only way they have been getting paid is by doing visits, not by answering phone calls or reaching out to patients, but by visits. And so at the very time that we need primary care the most, we see more and more practices who are in fee-for-service at threat of going out of business. So it's not a good time for primary care. They're worried about themselves, they're worried about their family members, they're worried about their staff, and they're worried about how to make payroll.
I'm wondering what you think needs to happen to save these practices from financial ruin. I've talked to experts who have called this a potentially extinction level event for small practices. Yeah. What needs to happen both from a policy level and just in terms of what physicians can do to try to keep afloat?
So today, and this is quite topical, today Blue Cross and Blue Shield of North Carolina announced a program that we've been working with them on for some time now, where they are leading the way, honestly, from any health plans thinking in terms of what should be done to save these independent primary care practices. And quite simply, what they're saying is, we will give you a lump sum payment to make up the loss of revenue that you had this year.
Wow.
There's no clawback if they miscalculated. There's no additional reporting requirements. The one requirement is that you enter into a ACO contract, a Blue Premier Total Cost of Care Accountability contract, and Aledade is honored to be the partner in helping support those practices and succeeding in those value-based contracts. And guess what? If you're in those value-based contracts, now you're less dependent on just fee-for-service. And we have our North Carolina practices, like other parts of the country, who are getting hundreds of thousands of dollars in payments, not for patients walking in the door, but for patients being healthy and at home and not having to go to the hospital. So they're really, that is the way, that's what we should be doing. We should be keeping independent primary care practices whole and using this as an opportunity to move towards value-based care.
I wanted to ask you about value-based care in terms of this pandemic has obviously had it's going to have huge ripple effects across the economy and healthcare, of course. How do you see value-based care evolving or changing, or the approaches that we're taking towards value-based care, given this sort of cataclysmic event that has occurred?
Yeah. I mean, what's interesting is it's a cataclysmic event as far as fee-for-service goes, with hundreds of billions of dollars of bailouts required to compensate hospitals and others for lost revenue from people not walking in the door for fee-for-service. Value-based care is fine, right? Like it hasn't needed a bailout, right? Like the models are actually, and we wrote about this, the ACO models are pretty robust, right? You still have to do better than yourself and than others during the time of COVID, right? You have to say, can we be better than if we weren't in an ACO? Can we respond faster to the needs of the patients? Can we educate the patients? Can we take care of their preventive care? Can we deal with care transitions? Can we deal with their medication issues? All of the things that we're working on with our practices to do a good job on the value-based contract is exactly what you would want to do for your mom in the time of COVID, right? You would want her primary care practice to reach out to her and let her know, like, you can call us. You can call us first. We'll see you on the video. We'll talk to you on the phone. If you have any problems, we'll send you a 90-day prescription so you don't have to go to the pharmacy in person. It's all the things that you would want done. And if you do end up in the emergency room, we'll call you and see how you're doing, follow up with you. That's what we should be doing anyway. It's just the current payment system didn't support it. So that is, ACO work is COVID work.
In terms of that virtual care, telehealth is obviously, utilization of telehealth has skyrocketed.
Yes.
What is the link between telehealth and value-based care, and how can we strengthen that link, both in terms of the provision of care and also making sure that physicians and practices are paid properly for the telehealth and remote monitoring and all those things that they're doing?
Yeah. So telehealth has had a long history of problems getting it paid for, because the concern on the part of the health plans and Medicare and others is it's not going to substitute for a face-to-face visit. It's just going to be additive, and it's going to increase costs. And anyone at the drop of the dime could be like, "Oh, sure, I'll call. Let me get a visit with a doctor," and that it's going to be harder to trace for fraud and abuse perspectives. All of those things are suspended now, because we can't get any face-to-face visits, and this is a substitution, a partial substitution for the loss of care. But when things go back to normal, and things will go back to normal, we will get through this. COVID will be conquered eventually. The question is whether this was just a blip or whether this is going to be the new way of delivering care. And I think people are being too optimistic to assume that all the flexibilities and the parity that has come with telehealth during this period is going to continue without, them not being worried about all the things they were worried about before. And I think the solution to that is taking risk. The solution to that is saying to the health plan, hey, we're not going to run up the bill on telehealth because we have an incentive to care about the total cost of care also. And so, more risk is more freedom in that sense, because if you're on the same side with the payer, then they'll be like, okay, you deliver the care however you want to deliver it. I don't care. Like, you want to do telehealth, group visit, in-person visit, phone visit, whatever, I don't care. Because you have the same incentive I do, keep the person healthy and out of the hospital, as opposed to run up the till.
Obviously at Aledade, you're in contact with a lot of physicians. What specifically are you hearing from them in terms of the challenges? You briefly mentioned it at the beginning, but can you talk a little bit about some of the challenges that your physicians are telling you about and some of the ways that they're dealing with them?
Yeah. I mean, one of the biggest challenges was the lack of PPE, and we went out and we had to become an importer of masks, and we found and donated about $2 million worth of supplies to these independent practices to help them stay in business. Another big challenge was around telehealth adoption. It's not just having the technology, it's knowing how to integrate it into the workflow. So we did a procurement, and we made it available free to them for the first 90 days. And we stand shoulder to shoulder with them as they implement it, virtually shoulder to shoulder with them as they implement the telehealth. So we went from 100 telehealth visits to 15,000 telehealth visits a day. And now 30-40% of all visits are done through telehealth. And there's still a lot more we can and should do in terms of improving the efficiency of that. One of the things we're hearing from them is that it's still not as efficient as it was when they had their whole office humming and the medical assistant is, rooming people and doing the survey. And the nurse talks to the patient and then the doc goes in and can be really efficient about the visit. With telehealth, we're still not there on efficiency. They're also worried about all the complexity of all these, there's been loan programs and state programs and payer programs and federal programs and SBA loans and EIDL loans and accelerated payments and provider relief fund. And they're worried that they're going to write some wrong thing on some form and they're going to get, called to court by the FBI about lying on a federal form. Like, that's what they're worried about. And they're doing it while they're working longer hours and making less money. So we need to simplify those relief programs for the independent practices who don't have a big team of accountants and financial consultants and so forth. And we need to help them be able to deliver more care. They're worried about their patients having untreated heart disease, untreated lung disease, untreated kidney disease. Those people they were worried about are still suffering with those, and we will see, I think, the rebound in the implications of that untreated, preventable hospitalizations.
One of the things physicians are dealing with right now, obviously, is walking this fine line where things are opening up in much of the country. We're also getting a surge in cases in certain parts of the country. And so you want to get patients in. You also want to treat patients telehealth. So you have to kind of navigate this fine line of doing what's right and keeping your business afloat. What are some ways to navigate these things? What are you guys sort of seeing at your organization of good ways for physicians to navigate these challenges, communicate with patients, those kinds of things?
The good thing about working with independent practices is that the North Star is what's best for the patient. Sometimes to the detriment of their business, right? Whereas, if you work for the organization that's got a big, finance department and they have bonds and whatever, then the finance people tell you how you should practice medicine. That's not the case with these independent practices. They do what's right for the patient. And what's right for the patient in this case is, if we can deliver care to you remotely, we should do it that way. And if you have potential COVID, then we need to keep you and other people safe. So a lot of it has been a lot of work done now in terms of creating new workflows and protocols for how to do testing in the parking lot, how to keep separate entrances, how to put people behind plexiglass, how to keep the waiting room empty. So we do have to reopen the practices so that we can get primary care in person to the people who need in-person care. But we got to do it in a way that's safe for the practice, safe for the staff, safe for other patients, and safe for the patients with COVID themselves. One of the things that we have to do to actually not just deal with COVID as a practice, but how do primary care practices on the front lines, how can they actually help control COVID? Has got to be earlier diagnosis and testing. So we have to give the practices the ability to diagnose and test rapidly and get those patients into the public health contact tracing programs.
Has your practices been able to get access to the testing supplies that they need?
Quite limited. We have a good partnership with LabCorp and Quest and others, but they are, it's a little bit of a catch-22 where there's a shortage. They're like, well, we'll only give you 5 swabs now. When you use the 5, come back and ask for more. And, the supply chain problems still are much better now, but they're still not totally solved. And, the reimbursement, frankly, is still not great, right? Because there's all these additional costs that I just talked about, setting up a parking lot structure and having nurses with full PPE and changing the clothes out and having separate rooms and disinfecting the room and all that kind of stuff costs money. And that's not put into the specimen collection fee costs right now.
So the next question I wanted to ask you is just about the strain and mental toll this is taking on physicians. I've seen surveys showing that rates of physician burnout are just really surging right now. What do we need to do what do physicians need to do as with their colleagues? What do organizations and just us as a country need to do to take care of these important providers?
Yeah, I'm very worried about burnout. I'm very worried about the pressures that are on our frontline primary care docs and staff. It's just the worry that we all feel and the uncertainty is just compounded when you're a small business owner. You're worrying about your finances. You're worrying about your employees. You have employees that you're accountable to. You may have to do layoffs. You may worry about their safety, and you're worried about bringing COVID home to your family. And I don't think that's appreciated enough. The daily toll it takes to go in, expose yourself, and then come home. And I know I've talked to one primary care provider who was like, I come home and I just like scrub myself raw. And that, that living with that is taking a toll. And I think we at Aledade feel like we have a call to service, and there's no one better to serve than these practices who dedicate themselves to caring for others. And so, that caring for those who care, I think we need that, and we need to, got to go beyond like bumper stickers or, signs that say thank you for the essential workers. Like, we actually need to, as a country, follow through on providing them with the support they need.
In terms of going forward, let's get more optimistic. What does the primary care practice, the ideal primary care system and practice of the future look like? Where should we want to go?
Yeah, I'm a cynical optimist. I'm the most optimistic cynic you'll ever meet, because I'm clear-eyed about what all the challenges are. But I really do think the future can be better, and I think the key for it is for us to really break the fallacy that fee-for-service is a good way to pay for primary care. And we've kind of limped along and like made it work, right? And been like, okay, well, I guess I can get paid for a 16-minute visit if I do these things and like punch these boxes, and then that'll pay for me to actually have the 40-minute conversation with a person who's with their family, and mom's getting demented, and we need to talk about end-of-life preferences and spend the time doing that, right? That is not compensated by the fee-for-service system, but we kind of made it work based on compassion and professional ethos. And now I think we're seeing like this is just no way to run the zoo, right? Like, we shouldn't be basing primary care payments on that. It should be on the value created. And we need to move towards more person-based rather than transactional. Primary care is very much of a person-based, longitudinal, relationship-based kind of work. And we should be paying for it based on person-based, longitudinal, and prospective, and holding people accountable for total cost, total quality, total experience of care. And I think that that's the optimistic view, is that we will get to the point where we're going to have more freedom for primary care to deliver care the way they see fit. You want to do a phone visit, do a phone visit. You want to do a nurse visit, do a nurse visit. You want to do a phone call, do a group visit. You want to do a televisit. You want to do an in-person visit. You want to do a visit in the home. You want to do it on the porch. You want to do it in where parking lot. I don't care. Like, you are responsible for this person. You own it. You take care of it. And I think that would be greatly appreciated, even more than possibly being paid fairly and being paid for the outcomes that we achieve. We are seeing in our practices who've even already embraced these shared risk, shared savings models, they're going to be getting, some of them, checks for $100,000, $200,000, $300,000, not for seeing patients, but for keeping patients healthy and out of the hospital. And I think they are going to be able to serve as the model for others.
Okay, great. In general, just like a broad question to finish up on. In general, what do you think the pandemic has revealed about our healthcare system, both good and bad?
I think we've talked a lot about the bad part, about how broken fee-for-service is and how we don't have the systems to really support these independent, smaller practices who don't have someone like an Aledade to help them with the regulations and the complexity of them, to help them with telehealth and the procurement of technology, to help them with PPE and the broken supply chain. So we really need to think about how to provide more support to these independents without creating consolidation. The plus side is you never thought you'd see things move so fast, right? We saw change within days on policy and regulations and payments models and technology adoption and telehealth. We saw change in days that you would have thought would take years under the normal course. So that, to me, is the positive, is that we have responded and our healthcare system can still, it's like, it's like getting up and sprinting and being like, oh, I didn't even realize I could still sprint, and so we have sprinted, and you can't keep sprinting, but it is a good reminder that we can do it when we need to.
Just a quick follow-up. How do you keep, you don't want to keep sprinting, but how do you keep the momentum, the positive momentum from a tragic situation, and not just revert back to the status quo? Like what needs to happen to keep moving forward rather than sort of taking a deep breath and stopping?
Yeah, I think we need to be, even as we're in the midst of an emergency, we need to be thinking around the bend. I think that's just one of the hardest things, and unfortunately what some of the health plans and payers, like I mentioned, Blue Cross North Carolina doing this amazing forward-looking thing where they're creating incentives for people to survive now, but also lay the road for the future. The sad part is that we're not seeing that from a lot of other payers yet. So the key is solve today's problems, but do it in a way that lays the groundwork for the future.
Dr. Mostashari, thanks so much for joining us today.
Thank you so much.